Good evening, everyone, and thank you for joining us tonight for the first of what will be a four-part webinar series focused on gastrointestinal cancers. By way of introduction, I'm Jill Lacy. I am a medical oncologist. I care for patients with gastrointestinal cancers here at Yale School of Medicine and Smilow Cancer Center, and I will be moderating tonight's session. I do hope that you come back and join us for the next three sessions. Will be highlighted here with topics and speakers, and let me get the screen share up. Yeah, so please come back on March 27th, April 24th, and May 22nd. Our goal for this four-part series is to provide a concise and yet comprehensive review of the many advances in the treatment of gastrointestinal cancers that we've seen over the last 1 to 2 years. So here is tonight's agenda. I'm going to kick it off with some updates in pancreatic cancer and rare cancers. My talk will be followed by Dr. Johung's talk, and she's going to provide some updates in the role of radiation therapy in treating gastrointestinal cancers, where there's been some recalibration and some major advances. And then we will finish tonight with Dr. Jeremy Kortmansky, who's going to be providing the updates in hepatobiliary cancers. That's been a busy space with some interesting new developments. We're going to save the questions for the end, so please put them in the chat as we go along, and we will try to get to those at the end. And we are committed to ending at 7:30 to let you get back to your dinner and your evening. Here are my disclosures. So I thought that I would start with this graphic, which I think really highlights the challenges that we face in the GI cancer space. So nearly a third of all cancer-related deaths in the United States in 2024 were due to gastrointestinal cancers. I think that's a really striking statistic. So GI cancers do in fact comprise the biggest slice of the pie when it comes to cancer-related deaths in the United States, exceeding the much more common cancers, lung, breast, prostate, urinary, and then all other cancers combined. And then I think what's also a little bit discouraging is that the only three cancer types where we're still seeing a 5-year survival that is less than 25% are gastrointestinal cancers, esophagus, liver, and pancreas. And then most recently, the data has shown, or the statistics are showing us that we are seeing an increasing incidence of GI cancers of all types in young adults, but particularly colorectal, as you've all heard. And now in people under the age of 50, colorectal cancer is the leading cause of cancer-related death in men and the second leading cause in women. So these are sobering statistics, but I think it's very clear that we are entering a new era in the treatment of gastrointestinal cancers, and I think we're going to see these numbers improve. And I think we're going to hear about these advances and have them summarized over tonight's session and the next three sessions, with many new drugs moving into the clinic. And I think this progress is real and is validated by the record number of new FDA drug approvals in GI cancers over the past year. And I put together a table of those approvals. I would highlight two bispecific antibodies have been approved, zanidatamab, and I'm sure we'll hear about that later, and zenocutuzumab, targeting HER2 and HER2/HER3. We have a new PD-1 inhibitor, tezepelumab, in gastroesophageal cancers. Encorafenib and cetuximab in combination with chemotherapy has been approved in the first-line setting in colorectal cancer. We have two tumor-agnostic approvals, repotrectinib and trastuzumab deruxtecan, in NTRK fusion-positive solid tumors and HER2-positive solid tumors. So this is exciting to have 8 new approvals in GI cancers and 2 tumor-agnostic approvals relevant to our patients. So my agenda over the next 15 to 20 minutes or so is to focus in primarily on advances in pancreatic ductal adenocarcinoma, PDAC. I'm going to highlight the readouts from 4 randomized phase 3 trials incorporating traditional chemotherapeutics in the locally advanced and metastatic space. And then I'm going to spend a good bit of time on really the exciting emergence of biomarker-based treatments in PDAC. Talk a little bit about some now potentially promising immunotherapeutic strategies. We've been challenged in incorporating immunotherapy in PDAC. And then, time permitting, highlight some of the emerging therapeutics that are earlier in development, antibody drug conjugates and bispecifics. And then we'll finish up with advances in anal cancer and, time permitting, gallbladder cancer. So I'm going to start with LAPIS. At GI ASCO last month, we heard the long-awaited results from LAPIS. So this was an important randomized phase 3 trial focused on those patients with non-metastatic, locally advanced, inoperable pancreatic cancer, which comprises up to 40% of our patient population. It is a subtype of, or a stage of pancreatic cancer, if you will, that has been largely neglected in terms of drug development, and there have been very few randomized phase 3 trials for these patients in the modern era. So this study was looking at standard of care chemotherapy, FOLFIRINOX or gem nab-paclitaxel, investigator's choice, compared to standard chemotherapy in combination with pamrevlumab. This is a monoclonal antibody that targets and blocks connective tissue growth factor and mediates remodeling of the desmoplastic stroma and tumor microenvironment. And in preclinical studies and phase 1/2 studies, this looked very promising in combination with chemotherapy with impressive resection rates. So here's the design. It's just a straightforward one-to-one randomization for locally advanced PDACs, ECOG performance stat of 0 or 1. Staging laparoscopy was not required, so probably 20% of patients going into the study had metastatic disease. Patients were treated for up to 6 months, and they were rigorously evaluated then for resectability. The primary endpoint was overall survival. This was a negative study. There was no difference in survival between the 2 arms, both at about 1.5 years of overall survival, which is similar to what we see in much smaller non-randomized trials in retrospective series. And there was no difference in the other efficacy endpoints. And disappointingly, less than 10% of patients in each arm were able to undergo resection, which of course is always the goal, but often not achieved in locally advanced unresectable pancreatic cancer. So it's a negative study, disappointing, but important. I think it gives us really meaningful historical control data now for incorporating novel agents into the treatment of these patients. It is the first large randomized trial that's been read out in locally advanced PDAC in the modern era with modern chemotherapy. It was rigorously executed, and they are conducting some correlative studies, which I think will provide new insights. Now, we also heard in a press release from Novocure that their study, PANOVA-3, was a positive study in locally advanced PDAC. This was a study randomizing patients to gem nab-paclitaxel versus gem nab plus tumor treating fields. This is a non-invasive treatment using low-intensity alternating electrical fields. This is really something that I don't know much about. This is applied, as you can see in the picture here, and has been shown to disrupt tumor growth. TT fields are FDA approved in GBM and non-small cell lung cancer. And in their press release, this was a positive study. It was a very large study, over 500 patients, with median survivals of 16.2 versus 14.2 months. So not a huge difference, but statistically significant with a hazard ratio of 0.819. I think we really want to see the presentation of the full data here to better understand this study and how we might want to incorporate this into our treatment algorithms. So I'm going to turn now to first-line therapy for metastatic PDAC. And I think for the past 12 to 13 years, the debate, if you will, has been whether we should use the triplet FOLFIRINOX or the doublet gemcitabine nab-paclitaxel. In the cross-trial comparisons for over 10 years ago, of the PRODIGE data with FOLFIRINOX versus GEM and the MPACT data, GEM-NAB versus GEM. FOLFIRINOX looked like it was more effective, although with more toxicity. So in the last 18 months, we've had readouts from 3 randomized trials, which finally have addressed this very important question for oncologists in the clinic trying to make this decision with their patients. So in 2023 at ASCO, and this has been published, we saw the data from NAPOLI-3, which compared NALIRIFOX, which is FOLFIRINOX with nanoliposomal irinotecan, against GEM-NAB, and that was a positive study for NALIRIFOX with median survival exactly as what we saw in PRODIGE with FOLFIRINOX of 11.1 months versus 9.2 months. But around the same time at ESMO, we got the readout of the JCOG 1611 study. This was also a randomized trial comparing GEM-NAB versus modified FOLFIRINOX as we are currently using it in the clinic. This was conducted in Japan, and this actually favored GEM-NAB with impressive overall survival with GEM-NAB versus FOLFIRINOX. So really discordant results here. And then at ASCO last year, we heard the readout, at least the preliminary readout, I think, from a very important study, PASS-01, again, comparing modified FOLFIRINOX versus GEM-NAB paclitaxel and metastatic PDAC. And here they've incorporated a really robust panel of correlative studies, which I think we will learn a lot from. Their assumption was that FOLFIRINOX would be superior with an improved PFS versus GEM-NAB paclitaxel, as you can see here. And this was a bit of a surprise in that the PFS and OS actually favored GEM-NAB, and that FOLFIRINOX did not perform as expected with an overall survival of only 8.4 months. Now, there are some caveats here. This may have been a poor prognosis cohort compared to historical controls. But I think what we have to conclude is that really there's marginal benefit of first-line chemo in real-world patient population with poor prognosis patients. Only 44% of these patients were actually able to go on and receive second-line treatments. It also validated, and I did not show this here, the poor prognosis of the so-called basal-like subtype versus the classical subtype, and also supported that GEM-NAB paclitaxel is a better regimen for the basal-like subtype, and really highlights our need for biomarker-driven strategies in the first line. And then finally, I will just mention the Avenger study, again, long awaited and disappointing, huge randomized phase 3 trial comparing FOLFIRINOX versus FOLFIRINOX plus this metabolomic CPI 613, which looked very promising again at preclinical and early phase 1/2 studies in combination with FOLFIRINOX. This was a completely negative study, median survivals 11.1 and 11.7 months. There was a significant modification of the FOLFIRINOX dose in combination with CPI 613. And so I think what this study does support is that the modifications that we are routinely using in the clinic are not compromising efficacy. So in 2025, the debate is really, I think, resolved in that I think we can have clinical equipoise in choosing these, except we should certainly use FOLFIRINOX or consider a platinum-containing regimen in those patients who have BRCA or PALB. I think we are recalibrating our assumptions regarding first-line FOLFIRINOX versus GEM-NAB paclitaxel, and certainly can feel comfortable with GEM-NAB as a backbone in many of the studies where we are adding novel agents. We do certainly need predictable, reproducible biomarkers to help us select, which we still don't have. And really, most importantly, we need to incorporate novel biomarker-driven strategies into the first-line treatment. So with that, I am going to pivot now to a more exciting and optimistic part of the talk and review some of the biomarker-based treatments that are either FDA approved or are now moving into phase 3 studies. So I'm going to start with zenocutuzumab. At ESMO in 2023, and then most recently at ASCO GI last month, we heard the data from the Energy study looking at zenocutuzumab in NRG1 fusion positive PDAC. At GI ASCO, they presented the PDAC cohort of this study. So just the background here is that NRG1 is an EGF-like ligand that binds to HER3, promotes dimerization with HER2, and then promotes signal transduction, which is pro-oncogenic. NRG1 fusion, this gene fusion, is a driver oncogene in a small percentage of solid tumors, but KRAS wild-type PDAC and mucinous adenocarcinomas of the lung are enriched in NRG1 gene fusions. And the NRG1 fusion protein is resistant to proteases. It binds to HER2 and in an autocrine and constitutive manner activates HER3 dimerization with HER2. So zenocutuzumab is a bispecific antibody that binds to HER2, HER3, blocks NRG1 fusion binding, and blocks the signal transduction cascade. So this is the ENERGY study. It was a phase 1/2 global study for patients with NRG1 fusion positive cancers, comprised predominantly of PDACs and non-small cell lung cancer, patients who had been previously treated. Overall response rate was the primary endpoint, and we had the readout at GI ASCO in about 33 patients with PDAC. And so here's the waterfall plot, and this is a waterfall plot that we dream of. Nearly every patient had some cytoreduction, so very impressive disease control rate exceeding 90%, 42% overall response rate, deep responses. The responses were durable, and the responses were quick, which is important in the second-line setting. This was well tolerated, by the way, mostly grade 1, grade 2, nausea, fatigue, and diarrhea. So the FDA did approve zenocutuzumab, not only in non-small cell lung cancer, but also in advanced unresectable metastatic pancreatic cancer harboring the NRG1 gene fusion, and this has now just been published in the New England Journal of Medicine. I think this is really exciting. This represents only the second FDA approval of a targeted therapy specifically for PDAC. I think importantly now we need to be looking for NRG1 fusions. They are rare, but the impact for patients is huge. So this really needs to be done by RNA sequencing. We see this primarily in the KRAS wild-type patient population. So when we do our tumor profiling and we find that we're dealing with a KRAS wild-type profile, we should then go on and request RNA sequencing to look for the NRG1 fusion and actually other fusions as well for which we have tumor agnostic approvals. So I'm going to switch gears from this rare biomarker, but important, to a much more common biomarker, and that is mutated KRAS. And as you know, KRAS is mutated in more than 90% of patients with pancreas cancer. Most of these are point mutations in codon 12. And of course, for many years, we have considered this to be an undruggable target. Now we have 2 FDA-approved drugs targeting the KRAS G12C mutation, which is common in lung cancer, where in PDAC. But these drugs, adagrasib and sotorasib, are approved in lung cancer. There are others that are in clinical development. These 5 have been evaluated in small cohorts of KRAS G12C PDAC. All have shown positive signal with impressive response rates in a heavily pretreated patient population with reasonable PFS. And so this has really been proof of principle that we should be able to target KRAS and get clinical benefit. But the impact of targeting KRAS G12C in PDAC is limited, with less than 2% of patients harboring this particular mutation. I think so. What is exciting now is that a large number of KRAS inhibitors are in clinical trials that will have a much greater impact in the PDAC patient population. And I'd like to just focus in on one very exciting KRAS inhibitor, or RAS inhibitor rather, that I think is furthest along in its development and will likely be the first FDA-approved KRAS inhibitor in PDAC. And that's the Revolution Medicine RAS inhibitor, RMC-6236. And we heard the updated results from this inhibitor in PDAC patients at ASCO GI last month. RMC-6236 now has a name. daraxonrasib, which is a little bit hard to say, but that is the name for RMC 6236. So this is a pan-RAS inhibitor. It's a small molecule that binds to cyclophilin, forms a binary complex that then binds to all RAS molecules that are in the activated state and inhibits activated RAS. So it's a pan-RAS inhibitor. And here is the data that was presented at ASCO GI last month with this agent in the second-line setting. It's been evaluated in the third line and beyond, where it also has activity at the recommended phase 2 dose of 300 milligrams. And again, another very impressive waterfall plot with a response rate in KRAS G12X and all RAS in hovering 30% or so. And these, again, these are poor prognosis patients, pre-treated. And then they went on and showed for the first time progression-free and overall survival data. And I think this is most impressive if you look at the overall survival data in the second-line setting in PDAC with the 160 to 300 milligram dosing. It is 14.5 months. That exceeds what we see with first-line chemotherapy. So I think this is just incredibly exciting. It's a safe agent with a low incidence of grade 3 treatment-related adverse events, but a notable incidence of grade 1 and 2, and in particular rash, which can be very troublesome, as well as GI side effects and fatigue. So I think we can conclude that RMC 6236 is an exciting drug, well tolerated, with very encouraging, promising activity. And so it is going forward in the RASolute 302 study. This is a registration randomized phase 3 trial in the second-line setting, comparing RMC 6236 with investigators' choice second-line chemotherapy. As you can imagine, this is accruing rapidly, and we are hoping that we will get a rapid readout of this study and that this will go through to the FDA and ultimately get approved. And I'll just quickly mention there are many other RAS inhibitors in clinical trial, most still in phase 1. Revolution Medicine has a RAS on G12D selective inhibitor that also looks very promising with a response rate in pretreated patients of 30%, and that is ongoing in the second-line setting as monotherapy and in the first and second-line setting in combination with chemo, as well as RMC 6236. And then we have the KRAS G12D inhibitor that is a degrader, ASP 3082, and this is a novel mechanism of action. It promotes ubiquitination of KRAS G12C and its degradation, and that also looks promising. Again, these are small numbers and a story to be continued, but very promising. So we are now moving on beyond KRAS G12C inhibitors, where we will have a much greater impact in PDAC. And I think there's much work to be done. I think we're going to see a lot of exciting data emerging over the next few years. Obviously, durability of responses is still uncertain. Resistance, of course, is inevitable. We need to understand resistance mechanisms. And of course, ultimately, if we do expect that combinations will be necessary to enhance efficacy. And as you can imagine, there are many clinical trials ongoing with KRAS inhibitors in combination. So I'm just going to mention, pay attention to time here, another biomarker-driven strategy targeting PRMT5, protein arginine methyltransferase 5. This is a strategy that exploits a metabolic vulnerability in the 30% of PDAC patients that have MTAP loss or MTAP deletion. The sort of the background here is that PRMT5 methylates arginine residues in key proteins. It regulates a whole host of critical cellular processes that are important in oncogenesis. And if you don't have MTAP, you get accumulation of methylthioadenosine, MTA, which is an endogenous inhibitor of PRMT5. And that then, if we can further inhibit that with the targeted therapy, you get synthetic lethality. and that actually then can synergize with chemotherapy. So we've seen the phase 1 data in the second line setting and beyond with the Amgen AMG 193 PRMT5 inhibitor, which looks encouraging. There's preclinical data that shows synergy with chemotherapy, and Amgen has moved forward now with a randomized study comparing or looking, or actually, I'm sorry, a phase 1 study looking at AMG 193 in combination with FOLFIRINOX or gem-nab-paclitaxel, both in the locally advanced space and the metastatic space, and that is open at Yale. So I would just like to highlight the importance of the workup now in pancreatic cancer. We have entered the precision medicine era. So it is important in all of our patients with advanced PDAC to do next generation sequencing, preferably on tissue, but if you don't have sufficient tissue, to start with ctDNA. And for those patients that are KRAS wild type, we do want to go on and do RNA sequencing to look for the NRG and other fusions. And for those that are KRAS mutated, we have a number of biomarker-driven strategies. Of course, we still need to do germline genetic testing on everybody to look for BRCA, where we can utilize PARP inhibitors, and IHC, still looking for HER2 and mismatch repair deficiency, although the therapeutic impact there still is limited. And so I'm going to move on now and just highlight some of the, at least one immunotherapeutic strategy that is looking very promising. And that is trying to inhibit the metabolic immune checkpoint adenosine. So extracellular adenosine is a very potent immunosuppressive molecule in the tumor microenvironment, particularly in PDACs. And extracellular adenosine is generated by the sequential conversion of ATP to AMP to adenosine by the cell surface enzymes designated CD39 and CD73. So we can reduce and diminish the impact of the immunosuppressive adenosine by reducing its or inhibiting its production. And so we do have a small molecule inhibitor of CD73 called quemliclustat, which depletes the extracellular adenosine pool and reverses the immunosuppressive effect of adenosine. And this has now gone through phase 1 and 2 testing in PDAC. And this data has been read out at ASCO GI. And they looked at quemli in combination with gemabraxane, with and without their PD-1 inhibitor. And what they found was impressive activity with gemabraxane and quemli without the PD-1 inhibitor. So this combination, gemabraxane, quemli, is going forward now in a randomized phase 3 trial. It is placebo-controlled of gemabraxane versus gemabraxane plus quemli. And we do now have that open here at Yale and are excited to be able to offer this study. It is not biomarker driven. It is reasonable eligibility criteria. And this is very exciting. It gives us some hope that we may achieve success with immunotherapeutic strategies. And then I'm going to skip over the CD40 agonist story and then just mention that antibody drug conjugates, as you know, are very exciting therapeutic targets in oncology. There are 14 ADCs approved by the FDA in oncology, 14 or 15, 8 approved in solid tumors, but only 1 is approved in GI cancers, and that's trastuzumab deruxtecan as a tumor-agnostic approval in HER2-positive solid tumors. I would mention, however, that trastuzumab deruxtecan, although promising in biliary cancer, was disappointing in PDAC patients. Overall response rate of 4%. And so I think this is not going to have a big impact in PDACs, but much more so in biliary cancers. And so I put together a table highlighting some of the ADCs that are being evaluated in clinical trials. There's one focused on Claudin 18.2, which is overexpressed in the majority of pancreas cancers, so a good target for PDACs. Another one looking at tissue factor. We've seen promising phase 1 data for both of these, and so these are moving forward through the drug development process. And then I think I'm just going to skip to just reminding you that here at Yale, we have quite a robust portfolio now for PDAC in all stages. I highlighted the PRISM-1 study of chemo plus or minus quemliclustat. And we have a number of studies for KRAS mutated PDAC, particularly in our phase 1 unit, and other biomarker studies as well. And I did put together a table for the studies that are run through our phase 1 unit, where much of the drug development is still happening for PDAC. And I will skip over that in the interest of time, but it is in the slide deck here. And then I'm just going to finish up. I do have to mention, I think what will be a practice-changing presentation in a rare cancer, anal cancer, and this was the INTERACT-2 study that was presented at ESMO in 2024. This was a randomized phase 3 study comparing standard of care carbotaxol in advanced anal cancer compared to carbotaxol plus the PD-1 inhibitor retifanlimab, which is an FDA-approved PD-1 inhibitor in Merkel cell carcinomas. And this was a straight-up randomized trial, carbotaxol placebo versus carbotaxol retifanlimab. And again, this is in advanced anal cancer, locally advanced and metastatic. And this was a positive study for this PD-1 inhibitor with an impressive overall survival of 29 versus 23 months and improved progression-free survival. So I think this will prove to be practice-changing. This has been added to the NCCN guidelines. It's still a category 2B, but I expect with longer follow-up of the INTERACT-2 study that will move into category 1, hopefully in the metastatic advanced anal cancer space. And I will skip over the bladder cancer trial, which was not practice-changing, and conclude now with the key takeaways tonight, which is tumor profiling should and really must be undertaken in all of our patients with advanced pancreas cancer. And RNA sequencing should be pursued in those patients with the KRAS wild-type phenotype. Zenocutuzumab is a practice-changing, FDA-approved therapeutic for those patients who harbor the NRG1 fusion, who have failed or have progressed on first-line chemotherapy. So very important new therapeutic. And I think for all of our patients in PDAC now, given all of these biomarker-based therapies and novel therapeutics, we have to consider clinical trials, preferably in the second-line setting when patients are still eligible, I think really for all patients. And then in anal cancer, retifanlimab in combination with carbotaxol will represent, I think does represent a new standard of care for our patients with recurrent advanced anal cancer. So thank you, and I would like to acknowledge ESMO and ASCO. This material was taken from the presentations at these meetings, and certainly the authors of the presentations, abstracts, and papers. Okay, so that concludes my portion. We're going to now move on to Dr. Johung. And Dr. Johung is an associate professor of therapeutic radiology. I would highlight that she has played a major role in education here in our therapeutic radiology department. She is the vice chair for education, and she is the director of residency training, very involved in training the next generation of radiation oncologists. She also serves as the chief of our GI radiotherapy program, which is her clinical focus. And she's going to review some of the updates in radiation oncology for GI cancers.
Thank you so much, Jill. Thanks everyone for joining. We're going to switch gears. As Jill said, I'm a radiation oncologist, so we'll be talking about trials from this past year that were presented with some background data that we are all familiar with, just to put those trials into context. So let me just go into presenter mode. Here we go. Okay, so I'm going to discuss, as I said, practice changing. Maybe some of them are not always practice changing, so I'll say also thought-provoking studies presented in the past year related to radiation therapy and the management of GI cancers, really focusing on two studies presented in the area of esophageal cancer, and 2 studies presented for pancreatic cancer. And like I said, I will do a brief review of some prior studies just to try to put these into context for you. So I'm starting here with this nice little cartoon-looking picture, but what this drives home is that we know standard of care for esophageal cancer, other than really early stage tumors, would be preoperative chemoradiation followed by esophagectomy in those who are surgical candidates, whereas standard of care for gastric cancer is perioperative chemo. Many of the distal esophageal cancers or GE junction cancers were kind of bulked into some of the gastric trials, and therefore perioperative chemo could also be considered a standard of care for distal esophageal and GE junction tumors. And so this question of trimodality therapy with preoperative chemoradiation versus perioperative chemo has kind of been an ongoing debate in the area of distal esophageal cancer treatment since I remember starting to practice. So to review, we all know MAGIC trial rate showed us that there's an overall survival benefit to periop chemo over surgery alone in gastric cancer patients, and more recently, FLOT showed improved performance over the ECF regimen, so that established periop FLOT as standard of care for gastric cancers. Similarly, as background, the cross trial that we're familiar with, now published about 10 years ago, compared pre-op chemoradiation with concurrent carbotaxol to surgery alone in esophageal cancer patients. And the pre-op chemoradiation significantly improved overall survival, establishing trimodality therapy as a standard of care for patients with esophageal cancer who can be taken to esophagectomy. The overall survival benefit persisted up at a 10-year follow-up that was presented or published more recently. And from that analysis at long-term follow-up, we can see that the pre-op chemoradiation reduced isolated local regional relapses, but isolated distant relapse was comparable in the 2 arms, which indicates a need for improved control of systemic disease that we'll see in some of the next trials. This is another trial we're all familiar with, CALGB 80803, looking at whether we could optimize systemic therapy using PET to guide decision-making. And so patients were randomized to induction carbotaxol or FOLFOX, as you know, with an interim PET to determine the concurrent chemotherapy to go along with radiation. But what stands out from this trial is the improved response with concurrent FOLFOX, leading to a path CR rate of 40% and significantly improved over carbotaxol. And then finally, as background, adjuvant immune checkpoint inhibitor therapy was evaluated in the CheckMate study. As you know, here patients with esophageal or GE junction cancers who had received a standard pre-op chemoradiation regimen and had any path residual disease after resection were enrolled. This is regardless of their PD-L1 expression, randomized to receive a year of adjuvant nivolumab versus placebo. And we see that disease-free survival doubled with nivolumab, regardless of histology, squamous or adeno, and regardless of PD-L1 CPS score. And adjuvant nivo seemed to decrease metastatic recurrences, starting to address the need for improved systemic control. So moving into the more recent studies, there are 3 recent randomized studies shown here. The Neo-Aegis is how I say it. I'm not sure how it's supposed to be pronounced. Top Gear and ESOPEC studies that compared these 2 approaches, perioperative chemotherapy to preoperative chemoradiation in esophageal and or gastric cancers, 2 from the past year, which I'll focus on. So in this randomized Neo-Aegis trial, patients with esophageal or GE junction adenocarcinomas were randomized to the cross-trial regimen of pre-op chemo-RT with carbotaxol versus the MAGIC regimen of perioperative ECF or FLOT, when FLOT data became available, and that became standard of care. But note that only 15% of patients received FLOT on that arm. In the periop chemo arm, 41% of patients received complete regimen, whereas in the trimodality arm, 87% of patients completed the full treatment regimen, and fewer patients withdrew due to toxicity. Path CR rates and R0 resection rates were better with chemoradiation, but we don't see a difference in patterns of failure, local, regional versus systemic, between the treatment groups. And interestingly, there was no difference in disease-free survival or overall survival. So the improved path-CR rate with pre-op chemoradiation did not in this study translate into an overall survival benefit. This trial did close early due to an interim futility analysis and also the impact of COVID, so it was underpowered to assess non-inferiority of perioperative chemo. And results, right, the bottom line showed equivalent outcomes between a perioperative chemo approach and pre-op chemoradiation, but really a comparison of what we would consider now two suboptimal regimens: a cross-trial chemoradiation regimen with carbotaxol, which we know showed inferior outcomes compared to FOLFOX in that CALGB study, and a peri-op ECF regimen, which is outperformed by FLOT, and only 15% of patients in the peri-op chemo arm on this study received FLOT. So systemic failure rates were similar in the two arms, and really the impact of FLOT could not be analyzed in this comparison. So I'm going to move on to the Top Gear study, which was presented at ESMO this past year and then published in the New England Journal of Medicine. This is a study where over 500 patients with primarily gastric cancer, so a third of the patients had GE junction adenocarcinomas, but the population is mostly gastric cancers, were randomized again to a similar comparison of peri-op chemo plus or minus the addition of pre-op chemoradiation, basically in place of one of those pre-op chemo cycles. Again, the majority of patients received ECF, about a third received FLOT, so slightly more than the NeoAegis study. And concurrent chemoradiation was with single agent 5-FU or capecitabine in this study. In general, post-op treatment was not well tolerated. So in the pre-op chemoradiation arm, this was associated with a lower percent of patients completing post-op chemotherapy. If there was to be a survival benefit, perhaps this was offset by that decreased completion of post-op chemotherapy. And that was kind of a sneak preview of this slide. So we see that surgical outcomes were improved with the addition of pre-op chemoradiation. The percent of patients with a path complete response doubled. And there was a higher percentage of patients who had tumor downstaging and also nodal downstaging. Of note, in general, for this study in both arms, the path-CR rate was lower than expected or compared to other studies, perhaps related to the timing of surgery, which was at about 4 to 6 weeks after completion of pre-op therapy. But what we did see in Top Gear was that adding pre-op chemoradiation to peri-op chemo did not improve progression-free survival or overall survival, which really reinforces that there is a limited role at this time for radiation in the management of gastric cancers. If you look at analysis of treatment effect on overall survival according to baseline characteristics, there weren't really any subgroups of patients who clearly benefited from pre-op chemoradiation, but I do highlight this section based on location of tumors. So there was a trend towards worse survival noted among patients with tumors in the lower third of the stomach who received pre-op chemoradiation, and then a reverse trend of better survival with pre-op chemoradiation in patients where the tumors were in the GE junction, suggesting that maybe there still is a role to consider chemoradiation for the tumors that are more GE junction rather than gastric. So the ESOPEC study, which was presented at ASCO this past year, also published recently in New England Journal of Medicine, was more of an esophageal cancer trial, or was an esophageal cancer trial rather. So while Top Gear had about 2/3 of patients with gastric cancer, ESOPEC evaluated a similar comparison of peri-op chemotherapy versus preoperative chemoradiation in all esophageal cancer patients with adenocarcinomas. So over 400 patients were randomized to peri-op FLOT. So now all patients on that arm are receiving FLOT. And that was compared to the cross regimen of pre-op chemoradiation followed by an esophagectomy. The majority of patients in the peri-op arm completed all pre-op cycles of chemo, and about half were able to complete the whole regimen. Only 68% of patients completed all concurrent cycles of chemo with radiation, a little on the lower side than expected. And just over 80% of patients in both arms went on to receive a curative surgery after pre-op therapy. We didn't see any differences in post-op mortality or toxicities, serious adverse events. Unlike the top-tier study, in this study, path CR rates were actually lower in the chemoradiation arm. Perhaps this is in part due to the concurrent chemo regimen, the carbotaxol regimen that was used for an adenocarcinoma population. But notably, here in ESOPEC, we see a significant benefit for overall survival and progression-free survival with perioperative FLOT. So 5-year overall survival is looking around 50% compared to 39%, median at 66 months versus 37 months, and also a significant progression-free survival benefit. So where does this land us in terms of how we manage these patients? So conclusion of the ESOPEC study was that periop FLOT improves overall survival compared to a neoadjuvant approach, but that is a cross approach. So important points to consider are that path response is known to be inferior, as I mentioned, with concurrent carbotaxol at about 23% in the cross trial compared to 40% in the CALGB study. In general, for these studies that we're discussing, the more recent studies, the path CR rate was low in the chemoradiation arm, possibly related to timing of surgery. I'll go back to this slide. We also know that immune checkpoint inhibition improves disease-free survival after neoadjuvant chemoradiation, right, with a doubling of disease-free survival with the addition of adjuvant nivo in patients who had path residual disease after neoadjuvant chemoradiation. And so the question is, would the addition of that, how would that compare to a perioperative approach? Whereas so far, combining immune checkpoint inhibition with periop or post-op chemo has not shown improved survival in gastric or GE junction adenocarcinomas. So the addition of nivo to adjuvant chemo did not improve relapse-free survival in the Attraction 5 study. The addition of pembro to periop chemo improved path CR rate, but not overall survival rate in Keynote 585. And then in the Matterhorn study, addition of durva to periop chemo so far has improved path CR rate, but waiting for survival outcomes. So therefore, in putting this data together, should a combination of these approaches in a total neoadjuvant type of paradigm be considered, such as induction chemotherapy followed by chemoradiation, surgery if a surgical candidate, and then consideration of adjuvant checkpoint inhibition. So where do we stand with when we should think about employing or considering chemoradiation? I think from Checkmate and ESOPEC, the importance of managing micrometastatic disease and reducing distant recurrence was emphasized. We can certainly say that we still have a role for chemoradiation when the tumor is obviously in the upper esophagus, mid-esophagus, or squame. That's easy. Tumor in the distal esophagus or GE junction when a patient is not a surgical candidate and you're thinking obviously definitive therapy. But maybe still consider chemoradiation when you have a distal esophageal adenocarcinoma and a bulky tumor where you might want to decrease the risk of a positive margin at esophagectomy, or a patient should we be thinking about total neoadjuvant approaches which may improve outcomes? Adjuvant immunotherapy after induction chemo and chemoradiation and surgery will likely continue to be evaluated. Organ preservation and improved quality of life with that approach can be considered as our path CR rates continue to improve. And how does early response assessment, such as with things like circulating tumor DNA, help guide our treatment decisions? Okay, I'm going to totally shift gears now and talk about pancreatic cancer and two key studies that were presented this year. So starting with RTOG 0848, which was presented at ASCO in 2024. So we know that the standard of care for resected pancreatic cancer is 6 months of adjuvant chemotherapy, typically with FOLFIRINOX, with a significant overall survival benefit shown in all these studies summarized here. But the potential benefit of adjuvant chemoradiation continues to sort of be a topic of debate as well. And this was evaluated in RTOG 0848 which accrued over a long amount of time, but was presented, as I said, at ASCO. So this initially was a two-step phase 3 randomized study evaluating patients with pancreatic head tumors who had had a Whipple resection with an R0 resection in the majority of cases and R1 resection in 17% of cases. The patients were initially randomized to 5 cycles of gemcitabine single agent, plus or minus erlotinib. That arm closed after an interim analysis showing no survival benefit. This study was later amended such that patients in this upper arm were allowed who had received gemcitabine combinations or FOLFIRINOX rather than single agent gem. And then that group, if they didn't progress on their initial chemotherapy, were randomized to an additional cycle of chemo versus that with the addition of chemoradiation with concurrent 5-FU or Xeloda. Okay, so in the overall population, chemoradiation did not improve overall survival, did improve disease-free survival, 21% versus 15% at 5 years, without an increase in severe toxicities. If you look at the node-negative patients, both overall survival and disease-free survival were significantly improved with adjuvant chemo and chemoradiation, so 48% 5-year overall survival versus 29%. I think it's important to look at what systemic therapy these patients receive. So even though FOLFIRINOX was opened up as an option, none of the patients enrolled on this trial had received adjuvant FOLFIRINOX, with the majority of them receiving single agent gemcitabine and just a small fraction receiving gemcitabine combination. So not what we would consider optimal adjuvant chemotherapy at this time. So I think what we can conclude is that the addition of chemoradiation likely improves overall survival in patients with a lower risk of distant metastatic disease. 96% of patients in this cohort had a post-op CA19-9 that was less than 90. And we did see overall survival benefit on subgroup analysis reaching significance in node-negative patients. The benefit of radiation perhaps might be increased in the context of improved systemic control with FOLFIRINOX. So none of these patients received FOLFIRINOX. The majority received single agent gem. The benefit of radiation for local control in the setting of an R1 resection is presumed, radiation for residual microscopic disease, but not specifically addressed in this study, as the majority of patients had R0 resections. And then moving forward, a question would be whether neoadjuvant strategies afford more benefit than adjuvant. I think I'm going to put us back on time. So finally, I'm going to talk about the Extend trial, which was presented at ASCO GI also in 2024, published in the JCO this year. So this is an interesting trial in that previous studies, right, have demonstrated improved survival outcomes in several tumor types for patients with oligometastatic disease when metastasis-directed ablative therapy. We all have our different ways of total ablative therapy, referring to this local therapy to oligometastatic sites when that is added to systemic therapy. And given the propensity for metastatic dissemination, pancreatic cancer was presumed to be excluded from this paradigm. There have been some retrospective studies that show benefit in oligometastatic pancreatic cancer with the addition of local therapy to oligometastatic sites, leading to allowing time off systemic therapy. So the Extend was a multi-center phase 2 study evaluating whether adding comprehensive metastasis-directed therapy to standard of care chemo would improve progression-free survival over chemo alone among patients with oligometastatic PDAC with less than 5 sites of metastatic disease. And metastasis-directed therapy was SBRT in essentially all the cases. I think there were 2 ablations that were performed. Most patients had 1 to 2 metastases, either in the lung or the liver, with the primary tumor not having been addressed previously by a local therapy in about 60% of patients. All patients received chemo after diagnosis of metastatic disease, most often FOLFIRINOX or gemabraxane. And there was a mixture of patients who had de novo oligometastatic disease or oligorecurrent disease. And what was striking was that progression-free survival was improved significantly with SBRT to sites of oligometastatic disease. So at a median follow-up of 17 months, when this was reported, median progression-free survival was 10 just over 10 months with SBRT versus 2.5 months with standard of care chemo alone. And progression-free survival at a year was 40% in comparison to 9% with chemo alone. Time to next line systemic therapy was also prolonged from 8 months to 19 months. And there seemed to be a similar benefit for patients with CA19-9 less than 90 or greater than 90. That didn't, if your CA19-9 was greater than 90, there was still benefit. What is interesting is that systemic immune activation events are shown here are activated CD8 positive T cells, and T cell receptor diversity was associated with delivery of metastasis-directed therapy and correlated with improved progression-free survival, indicating that perhaps a mechanism of benefit to SBRT might be attributable in part to systemic immune activation. It's also possible that there's cytoreduction from SBRT that may, decrease tumor shedding or seeding of other sites, or the SBRT might address, tumor clones that may be resistant or have become resistant to chemotherapy. So I think this is a small study, obviously, but makes us pause and think about the role of local therapy to limited metastatic sites in pancreatic cancer. So I'm going to end there and pass this on to Dr. Kortmansky.
Thanks, Kim. That was a great summary. So our final speaker tonight is Dr. Jeremy Kortmansky. He is an associate professor of medicine here at Yale and Smilow Cancer Center. He is the clinical director of the Division of GI Oncology and the chief of ambulatory services. So he's very involved in making sure our practices are running smoothly. And Dr. Kortmansky said had an instrumental role in incorporating our community care centers into our program and bringing our clinical trials to the patients in the community. And Jeremy tonight is going to be giving us some updates in liver and biliary cancer.
All right, thank you. Hopefully everybody can see my slides. So I'm going to give the update in management of hepatobiliary cancers, really with a focus on hepatocellular cancer, where there has been a number of important studies that were presented or published over the past year. I have no disclosures. I'm going to start with a brief overview of hepatocellular cancer as a framework to discuss a clinical trial in adjuvant therapy, the IMbrave 050, the combination of local and systemic therapy with recently published LEAP 012 and EMERALD-1, and then a new systemic therapy for metastatic disease, CheckMate 9DW. And then at the end, just briefly review the recent approval of zanidatamab in HER2 positive cholangiocarcinoma. So as a background, hepatocellular cancer is the sixth most common cancer in the world, with more than 900,000 cases per year, most prevalent in Asia and sub-Saharan Africa. It is the third most common cause of cancer death, with over 800,000 deaths per year. 80% of those patients have pre-existing cirrhosis, with hepatitis B being the most common, then hepatitis C, and then other causes. Incident rates have stabilized in recent years because of effective viral treatments, as well as early detection. Although to a lesser degree, it's also a problem here in the United States, where there's 40,000 new cases per year. Men are affected about 2.5 times more often than women, and over 30,000 deaths per year. What is concerning is that the incident rate has tripled since 1980 and is the fastest rising cause of death in the US. And the etiologies of increased risk here include metabolic dysfunction associated steatotic liver disease, MASLD, alcohol-related liver disease, and hepatitis C. There are common molecular alterations in activation of oncogenic signaling pathways, mutations in TP53 and TERT promoter. However, there are no treatments with a differential benefit for these different molecularly defined subgroups. And so testing for molecular alterations is not standard, although we prefer to get that information, as it may have implications in clinical trials in the future. And the ease of ctDNA and finding those mutations has made it more available. There are a number of different staging systems for hepatocellular cancer, which make it confusing. But a lot of our treatment paradigms are based on the Barcelona Clinic Liver Cancer Staging System, BCLC. And the value of that system is that it looks at both the size and extent of the tumor, as well as incorporating underlying liver function and underlying performance status. Management of hepatocellular cancer very much requires a multidisciplinary team, including the hepatologists and transplant doctors, hepatobiliary surgeons, interventional radiologists, medical oncologists, and radiation oncologists. We have a weekly meeting here at Yale to review the active cases. Using the BCLC staging system as the backbone, it allows to create a paradigm of how we can treat hepatocellular cancer based on patients with early stage disease, BCLC 0 or stage A, intermediate stage B, and then advanced stage C. Patients with stage D are often those with poor performance status and advanced cirrhosis, for whom the survival is typically driven by their underlying liver disease rather than their hepatocellular cancer. So looking at early stage disease, this is a group of patients with small tumors, good liver function, and who are potentially curable with local therapies such as ablation, resection, or transplant. The survival rate for local therapy is about 70% at 5 years. And this is just a quick review of what those different techniques are. Ablation includes radiofrequency ablation or microwave ablation used for tumors that are less than 3 centimeters or non-surgical candidates. It excludes patients with tumors near the dome of the liver, major blood vessel or bile duct involvement, or larger tumors. Surgical resection offers similar survival and recurrence rates and is appropriate for patients without cirrhosis or Child-Pugh A, without portal hypertension, and can have an adequate liver remnant. Clinically significant portal hypertension or multifocal bilobar disease is typically an exclusion, for whom we would consider potentially transplant if there is severe cirrhosis precluding surgery and patients fall within the Milan criteria. Patients who are being considered for transplant can have bridge therapies such as TACE, SBRT, and ablation, but are excluded if they're unable to survive a major surgery or have extrahepatic disease. But even after these local therapies, there are risk factors for recurrence, including tumor size or burden, high AFP levels, vascular invasion, and a high tumor grade. And we see a bimodal curve of recurrence. Tumors can recur within the first couple of years, which often reflects micrometastatic disease. If they recur at 4 to 5 years, which is the second part of the curve, that usually reflects de novo disease, which is a consequence of the underlying liver damage. Many of the studies take into consideration vascular invasion and tumor burden, and so I think it's helpful to have some understanding of what those criteria are. And that is based on a classification system of the Liver Cancer Study Group of Japan that looks at VP1 through VP4. VP3 and VP4 are the larger vessel involvements of the main portal vein or the first order branches of the portal vein. And those are situations where local therapy is typically contraindicated. Patients with more segmental involvement of the portal vein may still be considered for local therapies. Tumor bulk has also been considered through a couple of criteria systems. Most commonly, we think about the Milan criteria, which is part of our transplant criteria. That includes a lesion that's 2 to 5 centimeters or up to 3 lesions with none greater than 3 centimeters, no vascular involvement, no extrahepatic spread, and an AFP level that is less than 1,000. Patients that are beyond the Milan criteria are typically considered to have intermediate disease and are not considered for transplant, although this is where bridging therapies or cytoreductive therapies may be helpful. Then there is the up to 7 criteria, which was developed by the Japanese groups, which looks at the sum of the diameter of the largest tumor in centimeters and then the total number of tumors. And if it is 7 centimeters or less, it's considered low volume, and more than 7 centimeters, then high volume. And so using these factors that contribute to recurrence, there has been interest in learning whether adjuvant therapy can improve the outcome in patients that have had curative intent surgery or ablation. The most recent iteration of this is the IMbrave050 study, which was published in The Lancet in 2023. This was a 1-to-1 randomization of patients with child A cirrhosis. The primary endpoint was recurrence-free survival. The 70% of patients on the study were from Asia Pacific and 29% from outside of that region. This included high-risk patients, vascular invasion of VP1 and VP2, tumors greater than 5 centimeters or more than 3 tumors, and then high-grade histology. The initial analysis of this study showed that there at 12 months showed that there was in fact an improvement in recurrence-free survival of the addition of atezolizumab and bevacizumab for 1 year. Patients received it for 1 year following their surgery or ablation compared to active surveillance. But this study is also a cautionary tale because with the second interim analysis, that early recurrence-free survival benefit was not maintained, and this was in fact ultimately a negative study. There was potentially a group of patients who were outside of that up to 7 criteria that I had mentioned that may benefit, but this was established within a post hoc analysis. And so the debate and the role of adjuvant therapy is still open. There are a number of other adjuvant studies that are in process, including Emerald-2, which is durvalumab with or without bevacizumab in patients with child A cirrhosis and no vascular involvement, Checkmate 9DX with single agent nivolumab, and then Keynote 937, which is single agent pembrolizumab. Switching gears to patients with more advanced disease, this includes a group that has a portal invasion, lymph node involvement, or extrahepatic disease. often still have adequate liver function, and the majority of clinical trials in the space included patients with child A or up to B7 liver dysfunction. And without treatment, this is a group with a median survival of less than 9 months. Part of this group includes those patients who are taste refractory, so no objective response rate, which means that there's more than 50% viable disease after 2 taste sessions. The development of a new HCC within a previously treated zone, AFP that does not improve after taste treatment, or progression of HCC with new vascular invasion or extrahepatic disease. For systemic therapy, there has been a lot of advances in a very short period of time. The first drug to show benefit was sorafenib in the SHARP trial, which was first published in 2007. There was then about a 10-year break without any new therapies coming into this space. But since that time, we now have a number of studies, including atezolizumab and bevacizumab, showing superiority to sorafenib in the IMbrave 150, tremelimumab and durvalumab showing superiority to sorafenib in the Himalaya study, the ipi-nivo CheckMate 9DW, which I will talk about shortly, and then the equivalence of lenvatinib to sorafenib in the REFLECT study, and the CARES 310 study, which looked at camrelizumab with rivosirinib, also superior to sorafenib. And so there's been a real progression of these immunotherapy combinations or immunotherapy with anti-angiogenic therapies replacing single-agent sorafenib in this space. So just as a reminder, this was the IMbrave 150 study, which compared atezolizumab and bevacizumab, showing significant improvements in overall survival starting at 6 months. That was maintained over 2 years with a median overall survival of 19 months and a 18-month overall survival of over 50%. And as a reminder, this is the Himalaya study. So this is looking at the STRIDE regimen, a single dose of tremelimumab, followed by monthly durvalumab versus sorafenib. And this study also showed significant improvement in median overall survival and a 4-year overall survival rate of 25%. And so these 2 studies led to first-line approvals of both the STRIDE regimen and the atezo-bevacizumab regimen. So this is where we enter CheckMate 9DW, another first-line study of combination checkpoint inhibitors, nivolumab and ipilimumab versus either lenvatinib or sorafenib. And this study showed improvement in overall response rates of 36% with the immune checkpoint combination versus 13% for the tyrosine kinase inhibitor, and an improvement in median overall survival, 24 months versus 20.6 months. Overall survival advantages were really maintained over a 3-year interval, and so a 40% 3-year survival rate was seen with the combination. And across all subgroups, that advantage of the nivolumab and ipilimumab was maintained. The other important piece of this study was the duration of benefit. And so patients who respond to the IPI and NIVO, which represented 36% of the patients enrolled, had a duration of response that was median of 2.5 years. So this data complicates the space. We now have 3 regimens that have demonstrated improved overall survival compared to sorafenib or lenvatinib, with fairly similar overall survival hazard ratios with immunotherapy, a improved overall survival with the Atezo-Bev. But median overall survivals are probably similar. None of these combinations have been compared with each other, and leaves us several options in the first-line setting. So what do we do with this information? We have three standard first-line options. Certainly assessing the risk of variceal bleeding and thrombosis is important when we consider a medication like bevacizumab. There are additional biomarkers that will be assessed in post hoc analyses from all of these studies. And then ultimately, if two drugs are good, maybe three drugs are better. And the Mont Blanc study is going to look at the combination of durva and tremi with or without bevacizumab. And so we see that for more advanced disease, there's clearly a number of options for systemic therapy. And so the question in the intermediate stage patients who are non-curative, but still amenable to local therapy, the question of whether additional systemic therapy can improve outcomes has been asked across a number of trials. The liver-directed therapy for these patients includes TACE, yttrium-90, which is preferred in patients that have portal vein thrombosis, and SBRT, which is preferred to ablation in patients that have small nodules near the dome or blood vessel involvement. And so these are a couple of early studies that were looking at tyrosine kinase inhibitors in combination with either TACE or TARE. These were with sorafenib, it was a negative study. With lenvatinib, there was an improvement in overall survival, progression-free survival, and response rate, but it was a population that was entirely Chinese with hepatitis B afflicting 87% of the patients enrolled in the study. So how applicable this approach would be to a Western population or a population with a different etiology to their cirrhosis is unclear. Earlier this year, there were two studies that were published in the Lancet Oncology. The first was the results of the LEAP-012 study, which was a one-to-one randomization of TACE with placebo or TACE with lenvatinib and pembrolizumab. This included 57% of patients from Asia, 43% from other, plus Japan. And in a lot of these studies, they separate the Japan from the rest of the Asian population based on the incidence of hepatitis B. The primary endpoint was progression-free survival. It included patients with child A and no vascular involvement, or patients with large tumors. This study showed an improvement in progression-free survival of 14.6 months versus 10 months. It showed a trend in improvement in overall survival, but this was not statistically significant, with a 24-month estimate of 75% for the treated group and 69% in the placebo group. The Emerald-1 study was also, recently published in the Lancet Oncology. This was a 1-to-1-to-1 randomization of TACE versus TACE with durva or TACE with durva and bev. But the primary endpoint was progression-free survival of TACE with or without the combination therapy. This study allowed a slightly higher level of liver dysfunction, including B7, and some vessel involvement, including the VP1 and VP2 patients. This shows a similar improvement in progression-free survival of 15 months versus 8.2 months. But overall survival data is not yet available. And so here again, we have two studies that demonstrate improvement in progression-free survival with addition of systemic therapy to TACE. Overall survival results are still forthcoming for Emerald 1 and not statistically significant for LEAP 012. And so I don't think that we are at a place where we have to uniformly adopt the results of this study. Awaiting final overall survival rates are important so that we perhaps don't relearn the lessons that we saw in the adjuvant study with atezo and bevacizumab. And also because we have so many options for systemic therapy, the overall survival advantages may be diluted by subsequent therapies. After first-line therapy, there are a number of second-line options as well, and this is a list of the different drugs that we can consider and the key studies that led to their approvals in this space. But one of the questions that comes up frequently is whether there is a role for immunotherapy in those patients who have already had a first-line immune checkpoint inhibitor. Some of this data that does come retrospectively. There was a retrospective series of under 50 patients, which shows a response rate of between 20 and 30% in patients getting immunotherapy after atezolizumab. At ASCO last summer, a study of regorafenib and pembrolizumab in patients who had previously had atezolizumab or durvalumab was presented and showed a median duration of response of only 2 to 2.5 months. And so the value in this setting is still unclear. There are a couple of studies that will look at this question further, including the ACCRU GI 2017 study, which is ipi-nivo in patients who have previously had atezo-bevacizumab, and then the IMbrave 251, which is atezo with lenvatinib or sorafenib in patient versus second-line lenvatinib or sorafenib. So hopefully we'll get some more clarity on this issue in a prospective manner. I just wanted to quickly highlight a couple of the HCC trials that are currently open at Yale, including the Morpheus Neo-HCC study. And so while there is interest in adjuvant therapy, there is also interest in neoadjuvant therapy and how that might impact the immune environment. And so this is a study that is looking at atezo-bev versus atezo-bev with an anti-TIGIT antibody in patients with HCC amenable to a surgical resection and Child-Pugh class A cirrhosis. And then the other is a first-line systemic therapy, the Morpheus Liver, which is a platform study for patients who are locally advanced or metastatic disease and have not received systemic therapy previously. Switching gears quickly to zanidatamab. This is a bispecific antibody against two non-overlapping domains of HER2. And there was interest for this drug in metastatic biliary tract cancers, and the Horizon BTC-01 study was a multi-center single-arm phase 2 study published in The Lancet in July of 23, which showed in 62 patients with IHC 3+ HER2 expression and one prior regimen, that there was an overall response rate of 52% and a duration of response of 14.9 months. A phase 3 study is currently in progress, but based on this phase 2b study And this very impressive looking waterfall plot, which shows activity across all of the different subtypes of bile duct tumors and gallbladder cancer. This drug was FDA approved in November of 2024 for patients with HER2 3+ bile duct tumor with progression on one prior gemcitabine-containing regimen. So in conclusion, HCC is increasing in incidence due to non-viral etiologies. Multidisciplinary management is mandatory in the treatment of these patients. There's no clear benefit for adjuvant therapy after ablation or resection, but work in this field continues. There are multiple options for first-line systemic therapy. There's an emerging role for systemic therapy with TACE or other local treatment. And zanidatamab was approved in HER2 positive cholangiocarcinoma. I appreciate your all staying late to hear my talk.
Thank you, Jeremy. That was a great summary of a very crowded space with trials. It's difficult to keep them all straight. We are just about at the hour. We are happy to take a few questions. I don't see any in the chat box. But if any of you who are still with us have questions for any of us, please feel free to reach out. Thank you very much for your attention tonight, and we will let you get your evening back.